Hello, it's my pleasure to introduce the research program in breast cancer that we perform at the UZ Brussels. Deep insertion breath hold increases the physical space between the heart and the left breast, and this results in a decrease in mean heart dose of 40 to 50%. And this is clinically very relevant, as Taylor and colleagues published a linear relationship between the relative risk of heart disease mortality and the mean heart dose, and they reported an excess relative risk per gray of about 4%. Over the last decades, we observed change in fractionations. In the early 1980s and 1990s, we were delivering whole breast irradiation in 25 fractions of 2 gray. Then, with the START A and B trials, we were giving 15 fractions of 2.67 gray, and more recently, the UK fast-forward study explored hyperfractionation in 5 fractions of 5.2 gray to the whole breast. And the UK fast-forward did not observe any statistically significant difference in ipsilateral breast tumor relapse between a 3 weeks and a 1 week treatment schedule. When we look to the adverse events in the breast and when we look to the patient and photographic assessment, they showed a higher normal tissue effect risk for 27 gray in 1 week versus 40 gray in 3 weeks, but not for 26 gray in 1 week versus the 40 gray. And from that time on, 5 fractions of 5.2 gray has become a new standard of care for whole breast irradiation in the United Kingdom and also in the rest of Europe, of course. We also went to hyperfractionation, but we performed a feasibility study of preoperative accelerated radiotherapy for early stage breast cancer. And in the POPAR trial, we delivered 5 times 5 gray whole breast irradiation with a simultaneous integrated boost till 30 gray on the tumor. And patients underwent then breast sparing surgery or sentinel node procedure 2 to 8 days after the end of radiotherapy. And we just reported the feasibility in the first 14 patients which had 15 clinically early stage breast cancer. So there was 1 patient with a bilateral breast cancer. And we observed quite some toxicity and some postoperative complications in the ipsilateral breast. 1 patient had a wound disruption, 3 patients needed antibiotics due to mastitis, and 1 patient developed a fistula needing a reintervention. And that's why we decided not to go to a phase 3 trial yet, but first to perform a phase 2 trial with smaller margins. And we really need to decrease the margins to 2 to 3 millimeters on the tumor, and therefore there's a need for intrafraction guidance. What are now the potential drawbacks of this ultra-hyperfractionated radiotherapy, be it post-op or pre-op? Well, first of all, we have a limited follow-up. We need 10 years or more of follow-up to assess the cardiovascular and secondary lung cancer mortality. And to overcome this, we performed a predictive model where we estimated the lung cancer and cardiovascular mortality in female breast cancer patients receiving radiotherapy for breast cancer. And we didn't only take into account the doses delivered to the heart and to the lungs, but also the score table, which describes the 10-year cardiovascular mortality risk and which is well known to you from your cardiological courses. And when we estimate the absolute 10 years cardiovascular mortality risk, you can see big differences within the population of women that we treat. When you treat, for instance, a 65-year-old woman with a systolic blood pressure of 180 millimeters of mercury, so a clear hypertension, who's a smoker and has high cholesterol levels, you can see that the absolute risk of dying from cardiovascular mortality is 90% without radiotherapy. And when you deliver 8 gray of mean heart dose, it increases till 23%. So there's a 4% absolute risk of dying from cardiovascular disease by the radiotherapy. When you irradiate, on the other hand, a 50-year-old woman with a normal tension and low cholesterol levels, the risk of 10 years of cardiovascular fatality without radiotherapy is 1%, and with a mean heart dose of 8 gray is only 1.2%. We also performed some modeling and looked to the absolute 20 years lung cancer risk in female breast cancer patients. And we based this analysis on the age, on the mean bilateral lung dose, on the fact that there's a first-degree family history of lung cancer, and on the smoking status. When we look here to women between 55 and 6 years of age. You can see here a non-smoking woman without a history of familial breast cancer, and you can see a low risk of lung cancer induction. There's a risk of 0.1% of a lung cancer without radiotherapy and only 0.2% when you give a mean lung dose of 8 Gray. On the other hand, when you take a woman of the same age with a familial history of lung cancer who's still smoking, you can see that she has already a 15% risk to develop a secondary lung cancer. And when you add your radiotherapy with a mean lung dose of 8 Gray, it increases to 39%. So there's a 24% absolute risk of developing a secondary lung cancer by the radiotherapy. Well, let's now take a look at the other potential drawbacks. Well, first of all, the daily treatment time increases as the patients need to perform more DBHs and there's a risk of drifting during the therapy. And third of all, the impact of positional errors can result in potential higher biological doses to the organs at risk as we deliver higher fraction doses and accelerated treatment. And I now would like to give the word to my colleague Thierry Gevaert, who will show you how we try to overcome these potential drawbacks by technological innovations. I thank you for your attention and I hope you have a nice ESTRO.